So we're still continuing on in Chapter 17. I will talk about specific emergency medical care for patients that are experiencing a potential neurologic emergency. So just over generalized, um, some conditions are a lot easier to identify and we can treat them in the field. Others are going to be not obvious at all, and it'll make it pretty difficult for you to do anything for that patient in the field. The only reliable way to tell if a patient is having a stroke or not is to do a CT of the head. That still doesn't definitively diagnose anything. It just shows that there's not bleeding. If the patient is still having stroke-like symptoms and they don't have a suspected seizure or hypoglycemia, then what they end up doing is going with, yeah, there's probably a clot in there. And they treat that clot either by breaking it apart with medications, if they're within the time window, going in and actually retrieving the clot. But they can't see an ischemic stroke on imaging until those cells actually start to die. So we're trying to catch it well before that. If that patient is having stroke-like symptoms and has a bleed, then that's going to change the course of action. They definitely don't want to give clot busting medication to somebody that's already actively bleeding. Some systems do designate specific hospitals to go to if you're having stroke type symptoms in a patient. Both of our centers here are able to take care of a patient the same way. We don't have one designated over the other, so you don't have to worry about that. But we do require a stroke alert for the ED so that they can get all of the people necessary there. There's really a limited number of treatments that are effective if they're started over 3 hours from the onset of the stroke. This isn't from the time the patient was noticed to have stroke-like symptoms. This is when the stroke actually started. So a vital piece of information is going to be, when was the last time the patient was seen normal? Patients who have had a seizure require evaluation and treatment in the hospital to make sure that that's truly what's going on, because several medical conditions can manifest in a seizure as well. So in order to take care of them, first and foremost, protect them from harm. We're not holding them down like we used to. We used to try and put a bite block in their mouth to keep them from biting their tongue and their cheeks. We don't do that anymore. We go ahead and allow them to have their seizure in an area that's safe so that they don't get further hurt. You may need to suction the airway to help clear it out. Provide oxygen as quickly as possible and in the best manner possible. Sometimes you have to get a little creative. If head or neck trauma is suspected, try and provide spinal immobilization. Trying to do that while somebody is actively seizing is trying to herd cats. I mean, they're moving around and you could actually cause more damage. So let them do their thing and then go ahead and take manual stabilization. For patients that continue to have a seizure, such as those that are in status epilepticus, suction the airway, provide positive pressure ventilation, and then try to transport to the hospital as quickly as possible. You may want to consider having ALS intercept the patient so that you can have them provide some medications that we have on board that could potentially stop the seizure so the patient doesn't have any ill effects of that. With headache, most headaches are pretty harmless. Yeah, they hurt, but they're not going to cause long-term disability within the patient. If the patient is complaining of a sudden onset of an extremely severe headache or a headache that is accompanied by fever, seizures, altered mental status or following a migraine, we want to be more concerned and definitely treat those patients a little bit differently. We definitely don't want them to refuse treatment if at all possible. Just let them know that there can be something underlying that they should be transported and evaluated for. For a migraine, you always want to assess the patient for other signs and symptoms that could indicate a more serious condition. Migraines manifest in very interesting ways, blurred vision, that sort of thing. And so we want to try and rule out anything that's more serious underneath of that, if possible. Definitely not possible for a lot of patients in the field. Provide high flow oxygen if the patient tolerates it or if they want it, if they're not short of breath. You could say, we can try some oxygen. Sometimes that does make it better. We're not going to want to throw on a mask and try and make them feel like they're suffocating, but a little bit of O2 via nasal cannula can see if that's going to make an improvement or change in your patient. If it does, maybe bump it up a little bit more. Try and keep things dark and quiet. Sometimes it's helpful to just lay a towel over their eyes, not their entire face, because that can make them claustrophobic, but just over their eyes to kind of help block some of that filtering light that could be coming in, especially if they're photosensitive or the light makes their pain more intense. For stroke, first and foremost, we're going to support ABCs and provide rapid transport because we can't really do anything in the field for them. They may require manual air positioning. You may need to utilize an airway adjunct if the patient is unconscious. We want to try and suction and maintain their O2 sat of at least 94. Depending on where their stroke occurred, they may not be able to swallow to clear their own airway of just simple saliva. So make sure that you go ahead and suction them as needed. Routine oxygen therapy is really only in patients that are in respiratory distress or showing signs of hypoxia. We don't want to just completely overload the brain. 94 is what we're going for. If they're staying at 94 or above, even if they are showing signs and symptoms of a stroke, if they're not short of breath, we're going to leave them alone with that oxygen. What we're going to end up doing is taking the patient in so that they can be evaluated for type of stroke, and then they may end up utilizing medications to break apart the clot or going in and actually retrieving the clot mechanically. This could completely stop the stroke if it's given within 3 hours. Most of the medications have to be given within 3 hours. There's some extended time frames, but just as a generalization, and they have up to 6 hours to go in and retrieve the clot mechanically. Comprehensive stroke centers offers, a lot of advanced care because that's their specialty. That's what they do. It's definitely better to take somebody to a stroke center if necessary. Like I said, here in Sioux Falls, doesn't matter if you go to Sanford or Rivera, they're both trained the same way and they both have the same or similar resources. So not going to be a huge difference for that patient. For seizures, the patient may end up being in a postictal state upon your arrival. You may not actively witness the patient seizing. So you'll start out just assessing and treating ABCs like you would with any other patient. The patient may or may not allow the administration of oxygen, and they may or may not need it. So kind of use common sense and critical thinking on that. If your patient is still actively having a seizure, it's really hard to prepare them for transport. We want to do that as safely as possible. We don't want to restrain them, but if they're continuing to have a seizure and we can't adequately care for them on scene, we are going to have to transport them. So make sure that you're protecting all of those limbs. Same with a patient with a stroke. I kind of skipped over this part, but patients that are having strokes, if they have that hemiparesis, they are not going to be able to control or even feel the arm, leg, etc. on that affected side. So we want to protect those parts, especially maybe tucking them in the seat belt, covering with a blanket, making sure that we're not slamming things against doorways. Elbows are notorious for smacking on doorways. The patient should be able to pull them in, but if they have that hemiparesis, they can't do that for themselves. So make sure that you get their elbows tucked in and that you protect their fingers from getting pinched because they won't be able to feel it. Injury's still there, they just don't feel it. But anyways, so back to seizures and altered mental statuses. Not every patient who has had a seizure wants to be transported. Oftentimes, those that have a history of seizure disorders know what has caused them to have their seizure. They might be on medications, but any sort of physiologic change to their health can actually cause them to have what's called a breakthrough seizure. So if they get sick, if they're abnormally stressed, that can cause them to seize irregardless of their medications. And they're like, yeah, I'm not going in. Then we want to definitely discuss with the patient the potentials of their refusing, just like anything else. Remind them that we can always come back if they change their mind. But definitely recommend that they be seen by their primary care because they should figure out why they're breaking through their meds. If the patient is refusing transport, make sure that you verify that they have the capacity to do that. Are they awake? Are they completely oriented after a seizure? They have to have a GCS score up around 15. Make sure that there's no trauma or other complications from their seizure. And then try and determine if this seizure was unusual for them. If it's not like their other seizures, then that's a pretty big indicator that they should be seen by somebody because there could be something else going on that's not what causes their normal seizures. And then for any patient that has an altered mental status, which can range from confusion to a full-out coma, truly, it doesn't matter what their symptoms are. Somebody with an altered mental status that is not normal for them. Some people are altered at baseline. They have some sort of disease process that this is just them all the time. If that isn't normal for them, we tend to regard that as an emergency, even if the cause appears to be intoxication or just a minor bump on the head. We still want to make sure that they get evaluated because we can't truly know for sure without some of that testing that we just can't do in the field. This is the last recording for chapter 17.